me try this. How about now?
This looks good. Yeah.
Great. And can you see my face as well?
Yeah, but you are like in the middle of your slides.
Okay. All right. If I get in the way of the slides, I'll move this way, that way. All right. Well, thank you, everybody. Like Kofi said, my name's David. I'm one of the internal medicine doctors at Brigham and Women's Hospital, but I'm also an ultrasound fellow. So Oni is one of my teachers, one of my mentors, and so I am very privileged to be able to give this talk in front of you all, um, and very happy to as well. So I have to start by saying that I am humbled for a chance to speak to so many doctors from so many different places. I think um, I have to be upfront about the experiences I have and how it's translatable to your scope. And as many of you know, in the US, because we have so many different types of specialists in our departments, that we have a more limited scope. So it's not just a matter of resources, but it's also a matter of the fact that cardiology here, once they're inside and admitted to the hospital, ends up doing a lot of pericardiocenteses. Um, a lot of the joint injections might be done by orthopedics or by rheumatology. However, as a doctor in other places, you don't have that privilege, and you are actually, in a way, if you think about it, privileged to practice all these things to help the patient in front of you in many different ways that sometimes require a little bit of creativity. So please take what you can from this presentation, but don't feel obligated to take everything from this presentation. Take what is relevant, leave what is not. So I want to organize my presentation by talking about three procedures, and I fortunately had a chance to sort of um, pull what kind of procedures you all might be most interested in ultrasound guided. And the three that we heard about was pericardiocentesis, which we'll talk about, and here's an outline, just the indications, talking about tamponade just briefly. Let me get out this way. And then a little video just showing a procedure demonstrated as well. The second one is vascular access. So vascular access, again, I think I'm just getting right in the picture. I'll come out this way. Vascular access, including ultrasound guided IVs, which you may do more commonly, and central lines. And we'll talk about the different locations as well for central access. And then finally, I'll talk about arthrocentesis or in aspiration of joints. I think most commonly it will be the knee. So we'll focus our attention on the knee, but I've also included some things in the shoulder. And I'm going to keep my phone here close by just for me to be able to keep a track of time so that we get through all of the material today. And please feel free if someone comments in the chat, if someone wants to let me know and unmute their mic, I'm happy to be interrupted in my presentation, okay?
That's good.
Thank you. So first, our first chapter of our journey is going to be the pericardiocentesis. And so what is the indication for it? Well, tamponade. And what is pericardial tamponade? So it's an accumulation of pericardial fluid under pressure, which impairs the right-sided chamber filling, leading to a decrease in cardiac output of the left. So meaning that a lot of people will have pericardial effusions, but the mechanism by which the patient decompensates is that the right side has less pressure than the left, so the right starts to first be impaired, which eventually may also impair the left. And so a lot of times the pericardial effusions will watch, and we won't do a drain unless we feel like there's a clinical diagnosis and an ultrasound diagnosis of pericardial tamponade. So both pieces of information have to be put together. So meaning that, you know, if someone's in hemodynamic compromise and their blood pressure is very low, they're in shock, they're very close to coding, you see that pericardial effusion, and you may not necessarily want to make all these measurements. You may just proceed to doing the procedure. Conversely, you may see someone who is asymptomatic with a large pericardial effusion, and you may not want to drain it. You may do all the ultrasound signs, and though the ultrasound signs might say that the patient might have some signs of tamponade, you may not want to drain it and may want to watch it. Now, one other caveat to make is that most of the time, a larger pericardial effusion might correlate with a tamponade, but not always. People who might have a tuberculotic or a hemopericardium, they may actually have tamponade even with small amounts of fluid if it's focal in the area that might cause a decrease in cardiac output. So, it's a whole other talk to give in terms of the ultrasound signs of tamponade. But in a quick summary here, the first one is right atrial systolic collapse. And so a lot of times when people are starting to have fluid around, they'll have diastolic collapse, which makes sense, right? Because your atria is filling the ventricle during diastole, but once it starts to collapse in systole, that's one of the signs that we count. Similarly, the right ventricular diastolic collapse, right, is that the right ventricle is collapsing during diastole, and this one is actually the most specific. So keep that in mind. So if you have diastolic collapse, you know that patient is most likely to be in tamponade. And now the most sensitive one is actually here, the IVC being plethoric. Plethoric defined as greater than 2.5 centimeters with barely any respiratory variation. And let me just sort of get out of the way this way. There we go. And you can see right here that there's not very much collapse here. And then finally, the fourth one, which again, I won't go too much into, is going to be this one, which is the pulsus paradoxus. That's echographic. So echographic pulsus paradoxus, which is you put your pulse wave Doppler right up over the mitral valve, so between the left atrium and left ventricle, and you're looking at each beat and seeing each diastolic filling from the left atrium to the left ventricle. And these little lines are the velocity, so the Doppler of how fast it's coming in and out from the left atrium, sorry, just in from the left atrium to the left ventricle. And you can see if there's a 25% difference between inspiration and expiration in terms of that velocity, that's what we call echographic pulsus paradoxus. And so I know that was a lot of information very fast, but I'm going to give you this resource here to take a picture of, to get a QR code, which these are reference cards that help for you to study this another time, to sit down and actually sort of look at what that might mean. So as indicated in the beginning, hemodynamic instability from the pericardial effusion, so symptomatic pericardial effusion are, hemodynamic instability is one of the indications to go ahead and do this procedure, the pericardiocentesis. When it's actually symptomatic without hemodynamic instability, then it may be indicated to watch the patient and to see if the patient can do well without any intervention, and to see if controlling other factors. And so whatever the underlying cause is, whether it's an infection or if it's a structural heart issue that you can address, that may help the patient, or if the patient's also in congestive heart failure, to diurese to see if that will help. Now, contraindications for this procedure are a bit tricky because in urgent situations, acute situations, the contraindications are relative. If it means saving someone's life, all these things may be risks worth taking because the benefits outweigh the risks. So if someone's on anticoagulation like warfarin or heparin, if their platelets are less than 50, if they have coagulopathy, so from cirrhosis might be one of the common ones that you see. I would say that despite that not being a contraindication, if you are suspecting that someone has cirrhosis or someone is on an anticoagulation, I would just pay attention to that. So when you do the procedure as a practitioner, you know that between each steps, there might be more blood to watch out for. So you may, be better prepared by starting with more gauze, being ready to, put pressure as soon as you finish with every step. People might bleed right away, even with just a 22, 25 gauge lidocaine needle. They might be oozing blood from that. So just, even if you don't stop the procedure, prepare for the procedure if you think that the patient is going to be coagulopathic. Finally, one thing to keep in mind is that if the patient has hemopericardium, from a dissection or from a free wall rupture from trauma. So if you're ultrasounding it and it looks a bit like blood, or you're suspecting that this could be blood, um, pericardiocentesis is usually not indicated. It's a thoracotomy that's usually indicated, because usually when you put a catheter through, you may not be able to aspirate all the clots and the blood that's in there. So just keep that in mind as well, that if someone's coming in the trauma setting, or you suspect there's a dissection or a free wall rupture, um, that you take a step back to see if a thoracotomy needs to be done rather than the pericardiocentesis. Some complications to be aware of. Dry tap, and that can happen again because of the thickness of what's happening there. It can happen because there's not enough. It could also happen just technique wise. If you're coming in and out of so if this is the wall and your needle is just coming in and out, you may think that there's nothing there, but your needle might just be kind of poking in and out. Same with backwalling. If you backwall into the ventricle and your needle is over the ventricle that's beating, you may just not be getting fluid back because the lumen of the actual needle is not inside free fluid. Pneumothorax, we've got the lung obviously on the left side, and especially if you go subxiphoid, which is underneath your xiphoid, you have a chance of pneumothorax as well, and overlying the heart as well. There's lung that's coming in and out, especially if they're in respiratory distress. Myocardial injury, obviously, you're going through the pericardium and hoping not to hit the actual heart. So touching the heart or perforating parts of the heart are obvious risk. Arrhythmias, so by making any sort of contact with the heart, you may trigger some arrhythmias. Obviously, cardiac arrest from the needle perforating, and liver injury. So again, when you're going subxiphoid, it's expected that you will cause some liver injury because you're going through that area. So I think one of the most compelling things about ultrasound is that for this procedure, it makes a order of magnitude difference of how much complication it causes in our patients. And so that's why we advocate for using it for pericardiocentesis, especially because it can make a huge difference. Each pericardial effusion is unique and different. And by characterizing and using ultrasound, you can pick your best spot. It's not the best spot that the textbook tells you. It's the best spot that the patient in front of you is showing you that that's where it is. So there are three approaches to the pericardiocentesis. And traditionally, it's taught in the first one here, subxiphoid up here. And it's extrapleural, so it shouldn't touch the lung at all, though as you get closer, if you go anterior, posterior to the heart, it might. But the kind of the biggest known risk for this approach is that it's going through the liver and may actually make it through the colon and stomach. The other thing you might find if you practice the subxiphoid approach is actually the very long distance that it takes to get from the skin all the way to the pericardial cavity. And we'll show that, demonstrate that in later slides, but that's a pretty significant disadvantage. The apical is the one that is where we get our apical four-chamber view with the ultrasound, meaning that it's on the lateral wall. So maybe I'll just show the subxiphoid as well. So the subxiphoid here is down here. It's going to be right here. And then the apical four is going to be right here on the outside in that apical four-chamber view as well. And the advantage here is that since you're going to the apex, your needle is going to come through the pericardium, and it's going to be right. It's going to be a lot of times that's where there's going to be the most space, because the apex of the heart and the pericardium, there might be a lot of fluid in that direction. And the advantage is that it's very superficial and that it's right on top of the pericardial cavity. The disadvantage is that the lungs are right there. So depending on the person and depending on that location you go, you might actually, it may be impossible because there is a lung in the way. That is the same reason why if you are a practitioner of ultrasound and doing echoes, you might find that the apical four view is challenging. It's not just the rib spaces, it's also that the lung can get in the way. And finally, the left parasternal approach, which is sort of the parasternal long view, sort of right here. next to the subxiphoid, next to the xiphoid process. And that one, again, the direct route is what's beneficial about it. It's really close. Um, the needle doesn't have to travel as long. The other thing is the chance of pneumothorax. There is less lung overlying kind of more medially than there's laterally. The chance of pneumothorax might be less. However, the internal thoracic vessels run this way. And additionally, the pericardial effusion may not be the biggest in this area usually. So that is a disadvantage of this approach. So this is a study that was done to look at the approach, the parasternal approach. And if you look at this gentleman here on the right side of the screen, he's got his ultrasound probe sort of in a parasternal view, not in the same sort of clockwise or counterclockwise rotation, but right overlying where we would get the parasternal view. And he's doing it in long axis, meaning that the needle is going in the same plane as the ultrasound um, probe direction. And so in that view, you can see here in A that the needle, you can follow the needle track all the way down to the pericardium. And you can see the needle tip here with a little echo, which is an artifact. It's a shadow. And so this is the next step where after they put the needle through, they put the guide wire through and the needle has been removed. And so this was a case series of 11 patients where they've had 100% success in that. And so the myocardium that we're seeing here is overlying the right ventricle. But as you can see, it's a small amount of space. But it is a very promising area to do the procedure because if the pericardial effusion is large enough to have a nice pocket here, this might be the safest pocket. So there is debate about parasternal or apical being the best. And I think I've kind of outlined some of the benefits, the pros and cons of each. But I think ultimately the principle should be that you should go to where the largest fluid collection is. And so if you see it the largest in the apical view, go for the apical view. If it's in the subxiphoid view, go for the subxiphoid view. If it's in the parasternal, go in the parasternal. I think um, the the advantage of the parasternal and apical is that your needle doesn't have to travel very far. Remember, as your needle travels deeper and deeper and deeper, the ultrasound beams have difficulty detecting your needle tip, not just because it's deeper, but as you have to go deeper, the angle of the needle ends up being less than 90 degrees. And remember, 90 degrees, so perpendicular to the probe, is when the signal of the needle is brightest, and as you start to go more and more parallel, the ultrasound has a really difficult time detecting this needle. So you might have trouble visualizing your needle tip. So just in general, the steeper the angle of your needle, the more difficult the procedure will be. So if you're able to, with the patient that you have in front of you, try to catch the largest fluid collection with the closest to the skin, with the pericardium and the fluid closest to the skin, so that you don't have, so you can keep your needle visualization as optimal as possible. This is another view, which actually is not that great. So here are some pictures of the parasternal approach. And here's a pericardial effusion, the collapsing right ventricle. This is the mitral valve here. And it looks like actually we might have this in reverse, because usually we have the left apex of the left ventricle here. This is the left atrium, left ventricle, the aortic outflow tract here. But you can see we have a nice big pocket here, so this might be a good candidate for a parasternal approach for it. And so the next step is to identify the internal mammary arteries, which are usually a little bit medial. And you can see rib, so it's intercostal, and the probe marker is cephalid caudad. And you can see it's also right above the pleura. The internal mammary artery is right above the pleura, so right above the lung. So two approaches. You can go from the inferolateral side of the patient here. In fact, I think, or superolateral, depending on which way you think that the direction of the needle will best be guided into the biggest part of the pocket. but the lateral approach, lateral to medial, is what you want. And there's a couple of ways to confirm needle placement. You can see the needle first. Otherwise, if you've got one of those central line syringes, you can withdraw, and if you've got blood back or you got fluid back, you're all set. Or another way you can do this is if you've got a syringe. Sorry, if you have if you're using a long IV catheter, you can attach that long IV catheter and pull back, or you can flush saline, and you may be able to see the bubbles in the pericardial space before you put your guide wire through and before you do any dilating. So some people advocate for aspiration only. So meaning that if you don't have time, you've got other parts of the patient who, so this is a trauma patient who has multiple areas that need to be addressed or multiple things that need to be addressed, and you need to go quick in and out. It may be worth just aspirating 5-10 cc's, and it could be clinically significant to do so. I would still advocate that if you are going to do this, that you put either a long IV so that you can keep a catheter in there and keep the catheter to a lock, or keep a so that you can drain later on, or if you are using this needle here, to put the guide wire through and just put in the central line in there so that you can aspirate as needed. Great. I'm going to see what time it is. It's 11:30, so I may just show parts of this video. Let's see if we can walk through this. I'm going to stop sharing and share again so the audio will play through. Let's go again. Okay. Allow. All right, let's see if this works. Let's try it. I will send you the link because I think this video is very, very useful to look at. What they do in this video is they'll use an 18 gauge syringe, an 18 gauge IV. So they use a long IV to place it, and you can see it in real time. And you can see this person makes it look very easy, but they do it in less than 5 minutes.
Can it play from that slide or no?
When I press enter or when I press next slide, it's not play. You guys can still see. Can you still see my screen?
Yes.
Okay. Let's do it like this then. Let's take a look at it together.
As sterilely as your condition.
I'm going to jump through to the actual
Go through the chest wall. You want to stay the needle if inside the pericardium.
Okay. Going very slowly.
You can see how fast that part is moving, so you can see how it's quite scary to be placing the needle tip in the top corner of the screen.
There you go. So going very slowly. Find your tip better. So, find your tip. Okay, you're very close.
It's tenting the pericardium. Tenting the pericardium.
Okay, very good. Very good. Thread, leave it. Good. Good, very good.
There's the catheter.
That was really good.
And the needle's coming. Yeah, that's the three-way stop cough. love the music. I wish my presentation had more music in it. Maybe for next time. So these are the take-home points. Use ultrasound for pericardial fusion and for pericardiocentesis. Peristernal approach may be the safest if optimal, but you might have to go apicals and subxiphoid depending on what it is. If you can, use the central line only because the 18 gauge, if you put in just an IV and that's 18 gauge, you may have trouble aspirating more with like a large syringe, like a 50 cc syringe. You may only be able to aspirate 10. And that IV, because the fact that it's going through so much tissue and because the tip of it might be near a very active heart, that catheter might kink. And if it kinks, you may have to place the line again. And so if you're doing it very quickly and you need to do it with an IV, no problem, but just note that it may not last you a day or 2 or 3 days if you think you'll continue to need it. And yep, this is also a temporizing procedure. And so people may reaccumulate over the next couple of days. And so if you are putting something in, you may want to suture it in and have it available as the next couple of days if the patient's going to stay with you in the hospital. Great. So thank you for that. It's about 30 minutes in, so we'll do maybe 15 minutes of the other two, and I'll be happy to answer any questions. I'm gonna maybe stop for questions after this vascular access one, and then we'll do arthrocentesis at the end. So ultrasound guided IVs, I think we all learn how to place IVs, and I would say that a lot of our strategies and a lot of our technique we should try to remember when we're placing ultrasound guided IVs and not just forget and throw that out the window. The preparatory materials obviously are the probe, the tourniquet, the chloroprep or alcohol pad, whatever you're going to use to clean. And just keep in mind that you need a longer catheter if you're going anywhere that's 5 millimeters or below the skin. So usually the veins that we place IVs in just normally, we can feel within the first 5 millimeters, depending on the size, obviously. But below that, it's very unlikely that we'll feel anything. And one of the nurses who taught me how to place IVs always said that the best veins are ones that you can feel and see. And then the second best are the ones that you can feel but cannot see. And then the third ones are the ones that you can see but can't feel. And then the worst ones are the ones you can't see or feel. So that was the hierarchy that, if you can feel one but can't see it, that's better than one that you can see but can't feel. So similarly, all of these are going to be ones that you cannot feel or see, but keep in mind that your skills in having to keep the IV flat and to just go a little bit further before you thread your catheter through, all these skills are applicable. So when looking for a vein, I think looking for a vein is one of the most intimidating things in the beginning. And what you want to first confirm is that it's a vein and not an artery. So you can see here that this is the brachial artery, and then there's 2 brachial veins next to it. So you can see that the veins are compressible. The arteries are usually the pulsatile ones, but if you are looking really closely to the veins, oftentimes the veins can be pulsatile. It can fool you because it's transmitting the pulsatility of the artery next to it. So I would not rely on that by itself. Similarly, if you look very close with a good ultrasound, the actual arteries have sort of a second rim, a second hyperechoic rim with a thicker muscle layer than the veins do. But that's just one sign. I would say compressibility is going to be your main marker for whether or not that's a vein or artery. Now, keep in mind, people who are hypotensive, the arteries might collapse too. So if you put enough pressure, the veins and arteries will both collapse. So just keep in mind that when you put pressure, put it slowly and see which ones collapse first. And then if the second set collapse, that's because the arteries do collapse with enough pressure. So preferably the forearm veins are the ones that you want to go for first, but usually for us, we get called when the forearm veins are not accessible, so when they cannot feel it. You may want to ultrasound there to see if you can see some of the forearm veins here, the median vein of the forearm, the cephalic vein, the ulnar vein, the basidic vein. There's a lot more variation from person to person below the elbow. And as you go above the elbow, it becomes a little more standard. So today we'll just talk about three veins: the cephalic vein, the brachial vein, and the basilic vein. So if you scan someone sort of over the antecubital fossa, here, let me see if I can see myself. If you scan yourself over the antecubital fossa here, you'll find the brachial veins quite easily, the brachial veins and brachial artery right here. And you'll find them easily because there are usually three of them, three or four, depending on your anatomy, but they're all sort of in one collection. And usually if you go lateral to that, you'll see the basilic vein that tends to usually be bigger than the brachial veins. Now, these brachial veins, you just have to be careful because the nerve are all inside this bundle. So if you look, these are the two brachial veins, but then if right underneath this brachial vein is your median nerve. So you just have to kind of keep that in mind as you cannulate these veins. So the advantage of the brachial veins, cannulating the brachial veins, is that they're universally present, but the disadvantage is that, you know, they're close to artery, they're close to nerve. They're not dangerous if you kind of know what you're doing and you're familiar and you're not going through and through the vein. The basilic tends to be bigger and more superficial sometimes. The only thing sometimes with the basilic vein is that it's deep. As you go further proximal in your arm, they get deeper and deeper. And the deeper the IV is, just like we were talking about the pericardiocentesis, the more likely the IV is to kink over a longer period of time. But if you're just there to stabilize, you don't care about how long it's going to last. So there's two techniques. There's an in-plane technique this way, which we saw with the pericardiocentesis, which is with the needle and the ultrasound probe kind of in the same direction, and there's an out of plane. I would recommend out of plane to begin, and an out of plane technique is kind of demonstrated here, where if you look at the probe first, let's look at the probe and needle first. You first insert the needle just, I would say, like 5 millimeters, and then you find your needle tip. And when you find your needle, so let's take it slow here. So you can see the needle tip, the probe is stationary, and you can see the needle tip right here. And once you see it, at that point, let's see. So this is advancing the needle, and we see the needle tip a little deeper. And once you find your needle tip, only when you find your needle tip, then you move your probe so that the needle tip disappears again. And so the idea is that you only move one thing at a time, so that when you move the probe, then you advance the needle tip, then the needle tip comes back into view right here. And by moving only one hand at a time, you can maintain that the needle is where you think it is and not past. Because one common thing is for you to think that this is a needle tip, but the actual probe is in the middle of the needle. So be careful with that, that you are visualizing the tip every single time. You'll see that once we get close to a vein, there will be some tenting. You can see it right here in the vein. So there will be some tenting on the vessel wall. And as you tent, you have to make sure that you sort of pierce through, just like a central line, just like any other line. You sort of have to pierce through. And once you pierce through, you have to let go of the pressure to see if you're in the back wall, if you're in the middle, or if you haven't made it through at all. And once you're inside of the lumen, we do something calling walking the dog, or doing this technique of moving the probe, moving the IV, moving the probe, moving the to get the tip of the needle inside the vein a little bit longer before we thread the catheter. So here's an example. So you can see the needle tip, you can see the pressure coming through, and the needle tip is in right away. And so walking the dog means basically the probe is being pushed away so that it disappears, and then the needle tip is being followed, and you're keeping the needle tip in the middle of the lumen. So you move the probe away, tip disappears, then you push the needle, the tip comes into view, push the probe away, push the needle, push the probe, push the needle, so that you actually end up getting a lot of the needle inside of the vein. That way, when you advance the catheter, there it is about a third of it is already inside of the vein so that it goes in easily. One caveat I will make is that I think this practitioner, the angle of the insertion is a little bit too high. You can see that they're immediately in, and then they try to drop their angle. If you look, they'll drop their angle right there. I would say start at a shallow, and they drop it almost to 15 degrees or so. I would say come in at a shallower angle than that, maybe like a 45-degree angle, and then as you get right on the wall of the vessel, drop your angle so that when you pierce through, you're piercing through at a fairly superficial angle, because it's hard to actually follow your needle inside the lumen of the vein if you're going at it too steep of an angle. Because remember, the vein is basically flat to your skin, and so if you come in at a sharp angle, you're going to have a hard time trying to crank the needle to be conforming to the angle that you want. So if you come in at 45, get through the soft cutaneous and muscle wherever you want to go. Once you get to the wall, then drop your angle and then pierce through. So this is a demonstration of a long axis. And so what we're seeing here at this end of the clip is the vein in long axis and then compressing it and releasing it. So the benefit of this is that you can actually see the IV and seeing if it's tenting or if you're in the back of the vessel or in the middle of the vessel. But the disadvantage is that the actual width of what you see on the screen from the ultrasound probe is the width of a credit card. So if you just accidentally move it side to side a little bit, the vein walls will disappear. So this may be better suited for lines that are with veins that are bigger, and maybe more challenging for veins that are smaller and that are more tortuous or more curved. So let's see, there it is. Here's a demonstration of that needle coming in at long axis, similar to the pericardiocentesis. And you can see this is a vein, but you can also see below that, that might be a vein or artery below that as well. And this is the catheter through. So we'll watch that video again, but you're going to see that they're looking at it first, vein, potentially artery, which you have to be careful about. And then halfway through, you can actually see the IV coming through, and they make it into the lumen. And here you would flatten your angle to get more of the IV in before threading your catheter. And then this is them checking the catheter that it's inside. Even if you don't use ultrasound to put in IVs, one thing you could do is you could use ultrasound to check your catheters. So once you put the IV in, if you're just curious if it's in a good place, or if the IV has been there for a day or two and you want to check if it's clotted, you can actually put your ultrasound over the IV that you have. And if the nurse is having trouble flushing it, you can actually attempt to flush it with the ultrasound there to troubleshoot what's going on with the IV. So just tips on how to increase success. If you can choose veins that are less than 1.5 centimeters, that would be great. It will also last longer, less likely to kink. Remember, when you're going up here, a lot of times you're going through muscle. So meaning that any sort of contraction of the arm will move the catheter and could kink the catheter. So if you want an IV to last longer, try to find a place that's more superficial. I would say ideally less than a centimeter. Well, a centimeter and a half is good. The other thing to be wary of is look at the markers on your ultrasound screen on the right side. If the actual vein size is less than 4 millimeters, it may be the only access you have, but it may be difficult because your vein is so small that it might be hard to get into the lumen of the vessel and be able to thread the catheter through because there's so little space. So we'll talk about CVCs. I'm at 45, so I've got 15 minutes. So I may go just a little bit faster. I think I'm just going to talk about IGs and femorals for today. And for us in the US, we tend to do IJs the most frequently. And part of that is because they're for long-term catheters, or by long-term, I mean more than just a day, like, for 2 weeks, temporary catheters, central catheters, the infection risk of the femoral ones are higher, and the subclavian ones are technically a little more challenging with ultrasound. They also have a higher risk of pneumothorax. So IJs are our preferred site. So we do these the most frequently. And if you look at the IJ here, a couple of tips I would give is, see if you can have the patient either flat or on Trendelenburg. And the other tip I would give is if you can have a pillow right underneath their shoulder so that their neck is hanging, sort of in the sniffing position that you would use to intubate someone, that also helps distend the vein a little bit more. And just like previous IV tips, just make sure that if the IJ and all these central veins are very collapsible. So with a needle, when you're right at the vessel wall, it'll collapse very easily. So it's very easy to go through and through. So to go through the actual front wall and then to end up in the back wall and then sort of skewering the back wall and the front wall, that happens quite frequently. My tip for that is that when you're tenting on the wall, see if you can drop your angle so that rather going in at a high angle, try to pierce the vein at a lower angle, and the going through and through is a little less common if you're able to pierce the wall. If this is the wall in the ultrasound screen that you're seeing, try to flatten your angle a little bit right at the end when you're tenting on the wall. This is the femoral vein, artery, and nerve. And so just keep in mind that you want to go above the area of where the greater saphenous vein comes out. So the femoral lines are higher than you think they are. So if you go into the inguinal crease, you'll usually see just two. So imagine that this isn't here. You'll usually just see two vessels. And as soon as you come down, the first thing that you'll see is that the saphenous vein will come off, and there will be sort of a like a Mickey Mouse type of sign here. So this is the artery vein and the saphenous vein that's coming off. That's the first structure that will come off of the femoral artery and vein is a saphenous vein. So just keep that in mind that you want to be either at the level of the saphenous vein or a little bit higher. Just in terms of orienting you, remember that the artery vein goes medial to lateral. So this is medial on the left side and lateral to this side, artery, vein. I'm sorry, it's the opposite. So medial is this way, lateral is this way. So meaning that the vein is here, artery is here, nerve is here. So meaning that this is closer to the middle, to the midline. These are the kits. Hopefully, this looks familiar to you. They're all a little bit different, so I'm sure you might have something that's a little bit different than this. Keep in mind one thing here. In these kits, sometimes, not in this picture, but sometimes they'll have the really long needle. Let's see if it's here, right here. They'll have the really long needle, which you should definitely use for femoral central lines. But sometimes the kits will also have a smaller needle. So this is, I think it's like a 7 centimeter needle, but sometimes they'll come in with a 4 centimeter needle. And so if you're doing an IJ in a small person, don't feel obligated to use the biggest, longest needle possible. You can use, as long as it's designated for the actual Rawlings syringe, that's what this is called. Then you can use that one and you can put the guide wire through that one. The other thing to note is that if you're having a lot of trouble with the central line and you need help, or if your trainee is having a lot of difficulty, in the back of this syringe here, actually there's a hole here where the guide wire can actually go through the hole. So meaning that if you've got the actual needle inside the vein and you don't want the practitioner, you don't want your trainee to move, you can just thread the guide wire from behind. The only reason why I wouldn't suggest it is only because if you put this needle here, this catheter and this needle and syringe takes up almost like 15 centimeters of your guide wire. So it's one of those things that I would use as a last resort rather than as a first pass method. This is another demonstration of the short axis approach that we talked about with ultrasound guided IV. And here's a simulation of it. And you can see the practitioner moving the probe, then moving the needle, then moving the probe. I would say that it's actually ultrasound guided IVs are technically more difficult in terms of the getting it into a smaller vessel. Now, the central lines are more difficult because the the veins are more tentable. There are more risky structures around. So in that way, and obviously you have to be sterile and it's a longer procedure. You have to dilate and put a guide wire through. So there are some other challenges, but just know that these skills translate over to each other. So if you're concerned about doing a central line, you may want to start by doing ultrasound guided IVs to give you some practice of the coordination between looking at the screen and advancing a needle. And again, even if you still continue to use landmark-based techniques for putting in central lines, I would advocate that maybe if you don't feel comfortable putting in ultrasound guided, just go ahead and pick up the ultrasound with a sterile probe cover after you place your guide wire. Because once you've finished the procedure and you have the guide wire, you can usually see the needle very nicely kind of go down this way. You can often sometimes catch, so when you put the central line on the left side, sometimes it'll go up into the right IJ. So you could actually check both IJs to see, did my guide wire or my catheter go up to the IJ? And you can prevent that. You can sort of readjust that before having to get the X-ray. So similarly to the pericardial effusion talk, you can also flush your central line after you've done it and look at the subxiphoid view. And if you just flush regular saline, nothing special, and if within 2 seconds you see saline in the right side of the heart, then you can confirm that this central catheter is inside the SVC or at the brachiocephalic. Now, oftentimes when I do this, I'll flush it and I'll see it immediately. So I'll see it not less than 2 seconds, but like within 1 second or half a second. So take home points. Make sure you use a long IV for the ultrasound guide IVs because the IVs that are normally provided are for the ones that are right on the skin, but you're going to have to travel more soft tissue with ultrasound guided IVs. Choose a shallow vein, 1.5 centimeters, and choose a bigger vein if you can, greater than 4 millimeters. And then practice this probe, needle, probe, needle, probe, needle moving technique. And once you're inside the vein, make sure to go in just a couple of more millimeters with, and if you're able to, as much of the catheter can go in with this technique before you thread the catheter. For central lines, again, always use ultrasound, and you can confirm the guide wire with the ultrasound as well. So we're at 7 minutes. I'm going to take questions now, actually, and then if I have to cut off the shoulder, that's okay. I'll no pun intended. I'll just do the knee if because I think that's the highest yield anyway.
I don't see any questions in the chart, so let's do the knee.
Awesome. Okay. So the technique with the knee is right. So everyone has different techniques. And so if you do these procedures, the arthrocentesis blind, there's a couple of different ways you can go. But for ultrasound guided, because we have a second thing that we have to put on top of the patient, the lateral technique tends to be the best. So keeping the probe sort of transverse across above the patella. I would advocate going laterally for a couple of reasons. Number one is that more of your quadriceps muscles are medial, so you go through less structures by going laterally in terms of muscle tissue that you're going through. And the second thing is that it's easier as a practitioner to put your ultrasound probe across from you and sit laterally as your needle goes across. One thing I'll note that is not true of other procedures is that for the knee, remember what I said about the needle angle with the probe. As much as possible, you want to be 90 degrees to the probe to visualize the needle the best way possible. So what that means for the knee, you don't start right where the probe is. You actually will go down a couple of centimeters and then allow this needle to be seen by the ultrasound probe that's waiting for it right here in the midline. Now, how much lower do you start? And so a good rule of thumb is however deep your cavity is, your synovial fluid is, however deep it is from the skin of where you want to end up, that's how many centimeters down I would go. So if it's 2 centimeters deep, I would go about 2 centimeters down, starting out with the needle. So here are some materials. for the most part, the setup is the same. The only thing I would sort of tell you is make sure you get yourself a spinal needle here. The spinal needle, so you can have one, so this is for numbing the skin, and you can have one to numb up the patient, and then you can either keep the needle in there and then exchange the syringe to draw back fluid, or you can use two separate needles if you'd like. But spinal needle works well. Just keep in mind that if your spinal needle is smaller than 22 gauge, it will often bend and it may not fully make it there. So I would recommend using a 22 or 20 gauge, depending on how thick your patient is. So just to discuss some of the anatomy here. So on the screen, this is medial lateral. So we're looking, this is the patient's medial side, lateral side. And remember, the needle is coming in from this way. Sorry, I think I indicated this is incorrect. I think it must be this way, coming in laterally. So what we're aiming for here is the quadriceps tendon. So meaning the quadriceps tendon is coming in and out of the screen. So we were looking right now, here's the femur. So when you're looking at the screen, you're basically looking up at the patient's head, and then the quadriceps tendon is coming towards you like this way, out of the screen towards your face. And so the quadriceps tendon is running like this, up and down like this way. And what we're aiming for is right below the quadriceps tendon is this suprapatellar recess, and this is where the fluid collects. So how do you find this? Well, in a physiologic patient, if you're doing a knee injection, it's a little bit difficult. You may not find it right away, but if someone has any sort of effusion, you'll see this anechoic or hypoechoic space. And again, we'll come in lateral to medial. So we're going to try to end up with the needle this way. And that's why, the needle, instead of coming in this way like our IVs have, you're actually going to see it come straight across this way, because we're starting 2 centimeters deeper and keeping the needle angle fairly parallel to the floor. So here's an example of a video of the spinal needle coming through laterally to medially like this. And this is the fluid. And you can see the fluid quite strikingly when it's there. And you can see the practitioner has a needle tip here, and the synovium, actually they went a little bit through and through. So then they come back out. And now at this point, you're aspirating fluid. Now, as you aspirate fluid, you'll see the cavity close, and you see this practitioner is trying to get a little bit, and you can actually, this practitioner I think is aspirating right now, which is why you're seeing some motion happening here. And sometimes the needle, exactly, it will lodge over here if, as you're aspirating, the fluid is getting sucked. So remember, there's negative pressure into the needle because you're trying to aspirate the fluid. So as you aspirate with one hand, or have someone aspirate for you, but I usually aspirate with one hand and I look with the other, I keep my needle tip visible so that my needle tip continues to stay in the fluid as I aspirate all of it. I think if you just aspirate and you're not looking at the needle tip anymore, it'll often get kind of clogged up by synovium, and then you'll not get any more fluid and you might think you're done, when in reality there's more. And so it's more of a dynamic process of keeping that needle inside the synovium the whole time, as you aspirate back. The other thing too is you can have the assistant squeeze the medial aspect of the thigh, so the other side of the thigh, to see if you can get more fluid from the other side, like pushed onto your side. And then finally, I will discuss the glenohumeral joint aspiration, which is fairly uncommon. I feel like only in the setting of trauma or the setting of dislocations will you see some shoulder hemarthrosis. So just to remind you of the anatomy here, the humerus and the scapula meet, and the glenoid fossa is sort of the soft tissue that kind of connects the two areas. And so what we're trying to aspirate is from laterally here, right before the glenoid fossa, this joint capsule here, which you'll see here. And so it is a little difficult. I will admit to you that it is a little difficult. It is a different session to sort of go through the anatomy of the rotator cuffs and the shoulder. But imagine that the probe here laterally is the humerus. I'm sorry. Sorry, that is correct. It's just opposite, but laterally it's the humerus. So this side of it is the lateral side. And then as you go medial, this is where your labrum is, and then this is where your glenoid is right here, and your scapula is over on this side. So it's sort of switched to the demonstration that's here. So this is as lateral as you can go. And so the infraspinatus muscle is here, and then the muscle and the tendon eventually becomes tendon. So it's like a muscle tendinous junction here, and the deltoid above. And so the space where the fluid accumulates will be right above the humerus, below the infraspinatus tendon. This is where the fluid will accumulate. Another thing to look at is that with dislocations, right, most of the time people will dislocate their humerus anteriorly. So you might actually see a bunch of space. You might see the humerus down here, and you might see a lot of space here that is not fluid, just a lot of space. And you might see the infraspinatus coming down this way and the humerus all the way down here. In that case, you can diagnose somebody having an anterior humeral dislocation. So here is, so the image now is flipped. This is again lateral, and then this is the infraspinatus muscle. The glenoid is here. This is what normal is supposed to look like. And here's what it looks like with fluid inside of it. And this is what we're targeting going lateral to medial. So same materials as the knee injection. Remember, we're using spinal needles for deeper aspirations because our regular needles won't reach. So here's a demonstration of someone actually injecting something into the joint. So I wanted to show you, here's a needle going lateral to medial. Here's the infraspinatus tendon going into muscle. Here we talked, here's the labrum, and the glenoid is here, and the humeral head is right here. And then this is the deltoid muscle above. And so you can see the practitioner was able to get their needle tip right below the infraspinatus, and you can see the needle tip here, and then they're injecting bupivacaine or ropivacaine underneath this joint. And this is where the joint is, and this is where you'll see the fluid if you have to aspirate a shoulder. If you don't see an anechoic or hypoechoic space here, that means the patient does not have a joint effusion. And remember, the subacromial or subdeltoid bursitis is something different than having a joint effusion. So, and that's just a separate pathology, separate topic, separate thing. So if you don't see anything here, they have shoulder pain, they do not have a shoulder effusion. Okay, well, it's 4 minutes over, but I really, really appreciate your time. Thank you everyone for taking time out of their busy schedule to hear my procedural talks. I hope there were some tips along the way that were helpful. Please, if you have anything to say, if you want to confirm some of those things that you guys do what I say, or if it's something new, I would love to hear some tips or some opinions from you guys as well.
Thank you, Dr. Lee.
Oh, on your go on.
No, I was going to say thank you, but Kofi, please go on.
Thank you so much, Dr. Lee. I think there's a question in the chat box. What's your advice on patients who have a saphenous vein that's high up and very close to the inguinal line? Do you still go above the insertion of the saphenous vein or insert the catheter into the vein below the femoral vein below the saphenous vein?
Great question. That's a wonderful question. I would say that many people don't realize that they're going below the saphenous vein. So meaning that, before the age of ultrasound, we just did it landmark based. And so many, many of those lines are below the saphenous vein. And it's totally okay to go below the saphenous vein, totally okay. Just make sure you're not piercing the saphenous vein and the femoral vein. So after the saphenous vein, I think it's called the common femoral vein. So just with ultrasound, make sure you're only piercing one vein and you're totally good. Some people, which I would not advocate for, will actually go even lower. So they'll, instead of being up in the inguinal crease, they'll go ahead, and I'm talking about people who place dialysis lines for a longer term, just so that it's not right in the inguinal crease, they'll go kind of mid-femoral, and they'll place these like mid-femoral lines, which I would not recommend, but just to say that being at the level of the saphenous vein or lower than the saphenous vein is totally okay, because if you're doing a femoral line, guess what? Like, you're trying to get access quick. You're not doing it because they need antibiotics or something.
I have a question or two.
Yeah.
So, do you have any tips on how to handle cases where the images are not so clear due to patient's factors, maybe too much fat, too much muscle?
Yeah, absolutely. I would say in those kind of patients, try to find a vein or try to find a central axis that's very superficial. So meaning like for larger people, subclavian veins, ultrasound guided, not great because it's so deep to find that, the image quality is so poor, like you said. Same with femoral veins. Like if they're really large, may not be the best. So that's number one is like selection of what procedure or where you're going to go. Number two is this may be super obvious, but just decreasing the depth to the level that you absolutely need it and no more longer than that. And then if you are in trouble, like if you really need to do a procedure like a central line or pericardiocentesis and they're really large and there's no other way around it, just remind yourself that, 20 years ago we would have done it blind. And so almost use it as a guidance. So rather than like having to visualize your needle, just think of it this way, like I am actually I'm using the ultrasound to align where the femoral vein is and not the artery. And then I'm not gonna look at the screen. I'm just gonna look at my hands and I'm gonna go straight down right in the middle and the mid marker of my probe. And then hopefully with the aspiration method, I'm gonna get blood back. So if you're having a lot of trouble and you have to do this procedure and you have no help, um, just think of it as like instead of landmark guided, it's like ultrasound guided rather than like direct visualization, which is what we would optimally want. But like you said, if the body habitus is not perfect, the image quality is not perfect, you know, you having to have perfect images might discourage you from having to do an urgent procedure somewhat quickly. And if you have skills doing it landmark based, don't neglect those skills. Don't throw them away for ultrasound. I hope that helps.
Yeah, thank you so much. One more, if you don't mind.
Yeah.
For the joint aspirations, should you necessarily have a sterile field?
Great question. So I would say not like a central line, but I would say somewhat. So what do I mean by that? So I would encourage, so the practitioners that I've worked with, some of them have had no sterile field. So meaning they just use a chloroprep and then non-sterile gloves, non-sterile. But for me, it's the trade-off of like how, I guess, afraid are you that the patient could have an infection like subsequently from whatever you're aspirating? So meaning that like um I prefer to use a chloroprep more than alcohol and I clean more of the area. I prefer to use sterile gloves and keep my needle and keep my syringe and keep my field sterile. But if I'm totally by myself and I don't have help, then I will just make sure the needle is completely sterile, the area is completely sterile, my ultrasound is sterile, and in my hands I'll have regular gloves. And I'll always wear a mask for these sterile procedures because the respiratory part of it, I always worry about. But again, none of this is evidence-based. It's the way I practice.
Okay, thank you. We have a few more minutes for questions. So if there are any more questions, you can unmute yourself and ask, or you can still put the questions in the chat box.
Thank you for all the love. Thank you for all the kind words and gratitude. I'm very excited to I've gotten to meet so many of you. There's so many people here.
I don't see any more questions, Kofi.
Yeah, so I think that we can bring the meeting to a close. Thank you so much, Dr. Lee. Thank you so much, Onyi, for today's session. It's been an eye-opener. So guys, next month, the date will be made available to you soon. The date and the topic will be made available to you soon. So we'll meet again in a month's time. Thank you very much.
Thank you. I hope I can meet some of you in person someday.
Mhm.
Thank
Thank
you,
you.
Anya, for the invitation.
Bye-bye.
Welcome.